Let's take a look here. Good. So I wanted to welcome everyone tonight to our second ASES Research Committee webinar. Just to give someone, the people that are on, a little bit of a background, we started this program at the beginning of the year with the idea to be able to hopefully foster a little bit better understanding of both clinical and basic science research. And so far we've had one webinar that went off really well several months ago. And then the purpose of tonight's is to review basic science research in shoulder and elbow surgery. And so on the original schedule, we've had three surgeons that were and scientists that would be with us: Jim Johnson, Scott Rodeo, and Mark Frankel. Mark, unfortunately, is not going to be able to be with us tonight, but we have Jim and Scott, and I think it'll be a good discussions. So just to introduce both Jim and Scott. So Jim Johnson's a professor of within the Department of Surgery at Western Ontario in London. Or Western University in London, Ontario. He's currently the director of Bioengineering Research Lab, and he's going to talk to us about executing simple and complex biomechanical research projects. Scott is a professor of orthopedic surgery at Cornell Medical College and the Hospital of Special Surgery. He's currently attending and clinician scientist at HSS, and he's going to talk with us tonight about animal models in shoulder research. And so the format's going to be about 10 minutes of talk and then 10 or 15 minutes of discussion to follow. And hopefully we'll be able to get, a lot out of tonight's webinar. So I want to thank everyone. So again, just to introduce, I'm Bob Tastian. I'm orthopedic shoulder and elbow surgeon, part of the ASES committee, and Ty Lee, who's the director of the ASES Research Committee, is going to co-moderate this with me. So with that, we'll start with Jim. If you can bring up your slides, and we'll go from there.
Okay, is that visible?
Perfect, they look great.
Great, thanks, Bob. Thanks for the introduction, and thanks everyone for being here tonight. So over the course of the next 10, 12 minutes or so, I'm going to, as Bob suggested, talk about simple and complex approaches to biomechanics of the shoulder and elbow. So I'm going to start with a very basic engineering curve, and this is one that you've all seen before, I'm sure, in some capacity. It relates to what happens when you load or displace a tissue and or a joint. You end up generating a curve like this. You have a toe-in region, and I just raise that so you understand that if you're testing why that's there, it should be there. If it's not there, there's something wrong with the instrumentation or how you're fixing to whatever you're testing. And so that toe-in region is due to recruitment of soft tissues and even osseous tissues. More importantly is the stiffness, and this is usually the kind of holy grail of what we do, whether, again, it's looking at the stiffness of a ligament, of a replacement, or of whole joint stiffness. So that's generally the slope of that curve. And then sometimes we take things to failure, not very commonly in orthopedic biomechanics, but if you're looking at the strength of a suture or a screw, then obviously failure load becomes an important variable. So in terms of measuring outcomes, in particular stiffness, there's a few ways to do it. One is to apply deformation and determine a load. So you would do that. Conversely, you would apply a load and determine a deformation, and you would do that. So that's usually what occurs in 80 to 90%, if not higher, of most of the tests that we do. So again, we load it and we look at the amount of deformation or laxity in the system. So what do you need to do these sorts of tests? Well, if you need to measure load, and again, you don't need to measure load if you're adding or applying a load and measuring displacement, but there are times when you need a load cell, and so for most biomechanics lab, it's going to be there. So a load cell can measure either a uniaxial load, whether that be in tension or compression, or you can get a 6-Stoff load cell, which can measure 3 translational forces and 3 moments or 2 moments in a torque. And if you're kind of getting going with the biomechanical research laboratory and building it up, I would always suggest getting a 6, even though you may just need the 1 like the tensile measurement, for example, it's advantageous because other studies will emerge where you'd like to have more than one. So examples would be if you wanted to, put it into a reverse on the left or a total elbow on the right, and then those can be implanted into cadavers and loaded, and you can, look at studies related to a variety of different parametric differences or changes that you can occur across the joint. We've done that quite seriously in our lab. You can also implant it into bone. This is thanks to Graham King's abilities. He implanted a radial head load cell, as you can see on the lateral view at the top, and also an ulnar load cell, which is outriggered there. Now, the reason you see an osteotomy in the ulna, and there's one in the radius too, is that all the load needs to go through the load cell. So if you venture to do these sorts of things, you need to be cognizant of the fact that all the load needs to go through the load cell. Once you do it, it really actually a very cool approach to determining, for example, in this case, what the load sharing is at the elbow. So to measure displacement is probably the most common technique historically has been to use LVDT, which stands for Linear Variable Differential Transformer. This shows the concept of 4 of these being located around the glenoid component, which has these outriggers. And so they measure, if you like, the amount of motion of this outrigger, which is affixed to the glenoid relative to the bony anatomy. So how they work, on the left-hand side is the barrel, and it displaces, and you get your deformation or delta. So it gives you 1 degree of freedom measurement. It's probably better if you have the abilities to use a device. If you've got a tracking system, then you can measure 6 degree of freedom motion. And if you still want just 1 degree of freedom, you can take that out of the math. So those are obviously advantageous for a variety of reasons, and are easy to do. If I was to put it on that last test I showed on the glenoid, I just have 1 tracker on that ring, so to speak. And they're becoming more and more accurate, down to less than 50 microns, which is more than accurate for the vast majority of biomechanical studies we do when we're interested in things like joint laxity and stiffness. So measuring contact is not really related to load deformation per se, partially related, but more involved with what occurs at the articulation. So this shows a concept of using TEC scan at the joint, which gives you a contact pressure that looks like this. So as you can probably appreciate, this is a radiocapitellar joint. The top is a pressure profile you would get for the native joint, and the bottom is when you reconstruct the radial head with a metallic implant, you would end up having a pressure distribution like that. So TEC scan is a bit of a sensitive material. You have to get used to using it. It's best used in joints that aren't very conforming. So the radiocapitellar joint is quite good at that. A more conforming joint, like on the medial side, the ulnohumeral, can be more challenging. I've seen some groups use it, but they actually use 4 smaller transducers that they bring in, so it doesn't have to crinkle. But in our hands, and with a lot of the correct calibration, we've got to an accuracy of 5 to 7% relative to some companion computational studies. So you're going to be using cadavers in the lab. What do you need to think about? Well, first of all, we always have CTs done for 2 reasons. One, to ensure that the specimen's viable for testing. There's no significant osseous issues. And secondly, as you collect specimens, you build up a CT database, and that becomes valuable for a variety of reasons. You can do morphological studies with it. You can use those CT models to generate finite element models. So we have in our lab right now over 150, and we seem to use them all the time for those various reasons. When you're going to test, always consider preconditioning cycles, especially if you're dealing with a whole joint with soft tissue around it. Usually 1, 2, 3 preconditioning cycles, and then your 4th one would be the test cycle from which you get your data. And that's because of things like hysteresis and the recruitment issue and things like that. You can get up to 18 hours of testing if you're careful with your irrigation. We did a study where we actually looked at MCLs from rabbits, and we cycled them in the lab over 24 hours and looked at, we had irrigation on it. We looked at what happened over time, and really the mechanical properties were stable up to at least 18 hours. So typically most of us won't want to be in the lab for more than 18 hours. But if you're up there till that time, and that can happen if you've got, a joint that on a simulator, and there's lots of things to do to get to that stage to test from a time point of view, you may need to think about this. Typically 6 to 8 specimens is typically our floor in terms of how many you actually may need to test going forward. And then you do those and then you evaluate where you are from a power point of view. You may need to pump up those numbers. In terms of pilots, they're very important. One's not going to be enough. Likely you're going to have to do 2 or 3 depending on the complexity of a joint. Again, if it's a whole joint on a simulator, I would say 3 to 4 is kind of the minimum for us. Another thing comes about when you do pilots, more studies may emerge, right? So you're doing a pilot study to test your original hypotheses, but when you're in your lab and looking at other things, you can start to address, what's the effect of rotator cuff tension on an outcome variable. So you can actually add to the protocol, and you end up getting 2, 3, maybe 4 papers out of one cadaver, as long as they're all on a different theme. Always important to understand the loads you're dealing with. So we always consult Orthoload, which is, you're probably familiar with. It's an online database from a German group who telemetrized implants. So they have great data on the shoulder. And this just shows you one of many cases. Obviously, the patient is, he's got obviously a telemetrized shoulder implant in. He's doing overhead banging, or hammering, I should say. And what's important is in the top right, just to look at the kind of loading profiles that occur for the 3 different planes. And it's important to note how those load vectors change, not only with respect to magnitude, but also direction, because that affects how you test if you're looking at applying loading to a joint. So we need to be cognizant of that, not just for the coronal plane on the left, but also for the transverse plane. So it's starting to change how we look at testing shoulders, and starting to think about the outer plane direction. So when you're about to embark on a biomechanical test, I also often think about considering a simple approach first. So you do not need to use simulators of these sorts. You can think about some simpler studies that you can do with a very basic setup. So I'm going to talk very briefly about valgus stability of the elbow. This is actually April Armstrong's thesis work when she was in London 15 years ago. And so this is a study, as you probably already figured out. You're looking at the bottom right, you can see the palmaris longus graph for the MCL replacement. So I want to talk about the setup here. It's very, very straightforward. What we want to do, and this is a case where we're applying a load. You can't see an actuator here, but there's a load producing a valgus moment, if you like, with respect to the center of the elbow. Obviously, the radius and ulna are potted, as is the humerus. And so this load is applied by an actuator, but this could be applied using weights to keep it simple. And then our outcome variable is nothing more than looking at distance between these 2 targets to determine, if you like, the overall laxity of the joint. So in that study, we looked at different types of graphs, different types of fixation of the graphs. So as you can appreciate, it's along the lines of measuring stiffness by applying a load and determining deformation. So it's a simple setup, and it uses minimal technology. And from that, we were able to generate 2 papers on different aspects of that reconstruction. A more advanced study is kinematics of the shoulder. So this is where you actually want to take a shoulder and move it in a lab. It's probably, based on my experience, the most complicated testing procedure or approach that you could undertake for the upper limb. Why? Because the shoulder is much more complicated from a motion point of view than the elbow. We've done the elbow too with less difficulty. But this shows you a setup of one of our our Mach 1 simulator. I won't go through the details of what's labeled there, except you can appreciate there's a cadaver shoulder located here, and these are a series of actuators, and there's cables attached to them, and they're affixed to the deltoids and also to the cuffs. Looking at this from a different perspective, from an engineering approach, generating a CAD. Now, just kind of aside, I'm starting to think that anytime we submit a paper for publication, we want to submit this version, not the version on the upper left-hand corner. It's just more, I think, user-friendly look at, and that's where your engineering colleagues can help you with CAD images. So focusing on that one, what are some of the challenges of this testing? That being said, if you can achieve these tests and get the arm to move, it is quite the thing of beauty in the lab, and you can do a lot of things with it. However, if you haven't done this yet, time is a major issue. It takes usually 3 to 4 hours, at least in our lab. Usually the residents or fellows are doing it starting at 6 in the morning to get this specimen onto the simulator. They have to suture again all the tendons to the cables And then there's the original setup, and then you got to start to try and get it to move properly. And that part of that is getting the load magnitudes for the deltoids and the cuffs correct, and also how they're apportioned. And then you got to think about your constraints. Are you going to constrain it minimally? A lot of the simulators out there are starting to use a ring now so that you can gently guide it in the abduction plane if you're looking at the abduction motion. Well, one thing we're starting to realize now, if you've got a setup as shown here, you can do a couple of things. You can consider a wide range of protocols, right? So you can move the humerus and obviously get a myriad of data out of that, but you can also constrain it and then treat it as a static test to look at things like abduction force. So it's with all the effort that goes into getting an arm set up to do this type of testing, it's likely wise to consider different types of constraining. So you do both isometric testing and also kinematic-based testing. Very brief comment on sawbone, because it's important. You see it in the literature all the time, and you're likely been confronted with papers to review where they use sawbone. So there's two different types. There's the foam block, which is a surrogate for cancellous bone. You know, it works quite well, but I would only advise using it if you're looking at things like comparing different types of anchor fixations, maybe in a tensile pull-out mode. If you want to look at things like implants or plates where you're fixing it typically to cortical bone, you need to use the Gen 4. If you're doing, obviously, humerus work here, you'd use that specimen. And that's because you get much better purchase of that screw, or a more physiologic purchase of that screw in the cortical model, which is very close to the properties of cortical bone. Finite element analysis, I must say, I don't think I'd be comfortable flying on an aircraft these days if I knew there was not a lot of finite element work that went on. It's kind of the gold standard in the industry in terms of ensuring how load is transferred through a structure, and you appreciate what the outcome looks like in the bottom right there. Effectively, it's just a matter of taking one stress element, determining what the loads are, and then bringing it all together in a large matrix. And this shows you some applications for the shoulder, where you break it into all these different elements, and then you apply loads and determine stresses. The beauty of finite elements is that you can look at a lot more things than you can do experimentally, right? You can look inside the joint, you can look at the interfaces, etc. I was always a bit skeptical of finite elements with regard to absolute magnitudes, but we did a recent validation where we showed that there was excellent agreement within 5% between an experimental on the top and the computational on the bottom. So this is an example of what you can see in an articulation. For example, this is a capitellum looking at different types of radial head implants when you pronate and supinate, flex and extend. And you can't do that readily in the lab unless you're using TechScan properly. And finally, you can do quick finite element analyses. Actually, interestingly enough, you can download an app for, I think it's $4.99. Yeah, it's right there to look at things like plates if you're interested in doing that sort of thing. This analysis is comparing locking to fixed plates under tension. So just to summarize, both simple and advanced studies have their place. Advanced studies, if you're going to get to that stage and spend a lot of time and energy and money in getting a cadaver on a simulator, consider a wider range of protocols, and computational studies are complementary and permit further insight into those analyses. Thank you.
Jim, thanks. That was awesome. It was perfect. Exactly kind of what I was hoping for with regards to an overview of how to kind of potentially approach these types of studies. And obviously, a lot of us have done all of these types of studies in the past, but part of it gets to, okay, if you've never done this, or you don't necessarily have the resources to be able to actually initiate these, where do you start? And I know Ty has some questions for you as well, but one of the things that I think would be helpful, the people that are online, as well as when we actually archive this for people to go back to review the webinar, is, what would be your recommendation or advice for younger surgeons that have interest in doing research, but don't necessarily have great mentors where they are currently are at to be able to pursue this? Should they just say, I can't do it? or is there a strategy that you think that is available, that if someone's got the interest and the intelligence and the capability, but they just don't necessarily have the resources there that are with them, how would you approach that?
So, Bob, we would be talking about a young surgeon who's in an academic center, so there's likely a faculty of engineering there. So,
or non-academic. It would be good to kind of get your thoughts of both areas.
So it's always a value to try and secure an engineer, a research engineer, to kind of put things together, especially if you're dealing with things like load cells where you've got to wire them to a data acquisition system. But a lot of studies, if you keep them simple, they don't need to be complicated. And you can actually even use I didn't mention it, but you can use an iPhone to now measure displacements, right? Like that. Sure. The setup that April used, that if we were to do that today on a real low budget, we would be able to use an iPhone to track bone. We'd be able to use dead weights. We could probably put that together for less than $500 US to make it work. I think it's always good to have some form of mentoring, but that could be done remotely too. But the hands-on experiment to get things going, I wouldn't be intimidated by trying to do something like that, quite frankly.
Have you had any experience with surgeons that aren't necessarily local to your university to be able to reach out to you to kind of work in this area without necessarily having resources available locally?
Absolutely, and we've had some experience with that. A lot of times they come to visit to learn and then go back and start.
Sure. Yep.
But certainly,
that's another good point of coming and spending time evaluating a methodology. And we can get into that a little bit even when Scott talks with regards to animal modeling. That's probably, I think, one of the most valuable things is to be able to spend time, to be able to not waste resources in the process of being able to create what someone has already spent time and energy and money being able to create. So I think that's another great idea for even basic, biomechanical studies, that there a lot of value can be had by taking a visit, spending a couple of days in someone else's lab to see how things work.
Yeah.
Ty, any questions for Jim?
Yeah, I think I agree with everything Jim said. Especially to do biomechanical studies, it does not have to be complicated. It can have a very simple setup. And some of the most elegant studies are done with very simple setups. But the important thing for surgeons who wants to do research, get engaged in this, I'm sure you guys heard it many times, you guys talk about it in your lectures, that they have to get caught up with the literature. They have to have a fundamental understanding, very good understanding of the anatomy and the requirements, and to design your experiment properly. So even simple things like doing tensile tests or compression tests, you have to understand all the parameters, and you got to make sure you're measuring what you think you're measuring. A very simple example is that I've seen some papers that are submitted looking at tensile tests. You have a bunch of links of fixation systems, and you have the specimen that you're interested in the middle. And deformation is occurring at every single one of those levels. And you just take the measurement off the instron, and that's just very inaccurate. So simple things like that, I think through your training, some people get very good research training and some people don't. But when you don't, you can actually try to decipher some of those out of the literature, and also talk to people who are the experts. And most people are very open and will assist to that. So I think to add to some of the information that Jim gave out, that the other important part is even the simple tension compression test, there's a lot more information to get besides stiffness and ultimate load. And I know that's what surgeons love, and that's what they always talk about. There's a lot more things that are really relevant, especially in physiologic loading environment, not a high demand loading. So those toe regions are important. Cyclic loading and hysteresis on any of the constructs are important. energy absorbed, all those things, where you define the yield. So these are not complicated concepts. We've all had it as an undergrad somewhere, and they're very easy to extract out of the literature. And one thing I always do is I tell every young faculty, I tell them there's nothing that kills a great research idea like a good literature search. So they need to do literature search, and they need to try to understand some of the fundamental concepts. You have to do that before if you want to really engage in research, and then reach out to any one of us. We're always happy to help. The other thing I would like, I guess I can ask Jim to comment on it after I bring this point out, is whenever you do joint biomechanics research, it is critical for surgeons to, before they design a study, understand degree of freedom and also the force couples. So those are the two main things. Every linkage has a degree of freedom, and when you're doing an experiment, you're going to constrain certain aspects of degree of freedom, and you're going to open up certain aspects. But you got to do that properly, so you can measure what you think you're measuring. And I know Jim has a lot of experience with that, with the shoulder setup and elbow setup. Even loading medial collateral ligament in the elbow, if you just push down on it, there's going to be a translational component. If you constrain that, it's not going to you're not going to load it properly. So those are very simple things, but if you take a little time to look at it, you can see it. And I'm not knocking Jim's or my field, but biomechanics is not rocket science. I think what we're doing is we're observing what body is doing, and we're trying to put numbers on it correctly, so we can actually have quantitative information to control it. So, Jim, anything to add to what I was saying?
Well, that's a very astute point, Ty. I fully agree with that. I mean, example of constraint, for example, like if you think back to the April Armstrong's experiment where we loaded the ulna, we thought about that. How are we going to constrain it? Because, you know, if you've got it constrained and you've got an actuator coming down on it to produce a valgus load, if it's highly constrained, it's not just producing a valgus load, it's going to be producing torque and moment on the forearm, which is going to affect the outcome variables at the joint. So, you know, that's a case where you need to design it's not complicated, but need to design the correct linkage so that load is still, in theory, a point load being applied to the forearm. Same sort of thing applies when you're constraining the humerus in a shoulder test. A lot of things can go on there if you're overly constraining that when you're, say, trying to fire the deltoids and abduct it. If it's highly constrained, that's going to have a profound impact on how the humerus is articulating with the glenoid.
So again, I think for surgeons, I mean, you guys know anatomy better than anybody else. And if you're a young surgeon trying to do some of this research, you take that understanding in anatomy, and then you compartmentalize each one of the components, and you can try to put it back together. Again, it's in biomechanics research, we're trying to put numbers on what we're observing. So we got to be careful on what we're measuring and making sure that's what we think we're measuring. Go ahead, Bob.
The other thing that is it's interesting is, you know, obviously both of you have developed very complicated models to be able to evaluate the shoulder. And I, again, know, even based on grants that we've reviewed as members of the research committee, of people proposing grants that, you know, that just are not doable, probably with the resources that someone has, simply because of the amount of time and energy and money that it takes in order to actually establish something that is, I will say, I know you said it's not rocket science, but truly understanding kinematics in the shoulder at the level that a bioengineer understands it can be extremely complicated. And especially in understanding the axes with regards to how the shoulder is moving, it's fundamentally different than a lot of times how a surgeon thinks with regards to planes of motion and axes of motion. And so I guess one question is that, or I pose it to both of you, is that say that you've got a surgeon that is in an academic center that might be kind of aligned with a engineer that's doing simple, basic bioengineering testing, but wants to bring it to another level. Jim, I don't know, maybe you can tell me what was your experience with even translating or transferring your practice from something probably 15 or 20 years ago when you were maybe doing more push-pull, basic biomechanical testing to something extremely complicated like kinematic analyses using CT scans, using even FEA modeling. Was that techniques that you learned over time as a scientist? And, how were you pushed towards actually doing that from a scientific standpoint?
Yeah, well, certainly there was we started from humble beginnings in our lab. Graham and I had a lab in the basement of the research institute. We had a table and we had an Instron machine, and then we met there and decided where would we start. And our first study was calibrating or looking at the accuracy of the flock of birds, the tracking system, which really became our go-to for the next, 15, 20 years before we let, the optical systems take over. So, that then became on board with our first, we've called our simulators different Mach numbers. So Mach 1 was very basic, 3 actuators to fire the biceps, triceps, and brachialis. And then, we would move up to much higher levels where we would start to do things like instrument the joint to measure loads. We got into a situation or to another study where we started looking at the overhead position for bracing and things like that, which means we had to move the whole simulator on a hinge so that we could reproduce that motion. So it certainly escalates over time. But getting back to the point with regard to, the younger surgeons starting out, there's nothing wrong with doing simple stuff in the beginning, like what we did. And I still think there's a lot of studies out there that can be addressed quite simply using very basic tools, but probably needing somebody on the other end of the line, maybe a Zoom base where it's, talk to me or Ty or any of the others involved anytime with regard to helping out there.
No, go ahead. Oh, Ty, I was just about to say that, Jim brings up a really good point, and I think you probably would say it's true, is that having a committed collaboration with a surgeon and a scientist in order to actually do this to me has been the most critical element. Is that you cannot be the only person that's in this on your own. You need to have a committed relationship with the scientists that you're working with, just like you have done it with Graham as well as with George. I think that, and I think Ty, you've been successful even with Steve, with Steve Burkhart and with. We had said Pat Denard has done a lot of work with you. So, and over the years, you've had several scientists that have worked with you. I think Graham is and George have worked with you. For me, I've had Heath Henninger. Ty, you've had it a little bit different, where you've probably had more surgeons that have been collaborating with you over the years. How have you made that work? Yeah, Ty.
I think that it's really important point. Like guys like Jim and I, we couldn't do it without surgeons. But at the same time, I think a lot of the relationship as you develop, I think the key with my experience is having both surgeon and the scientist contribute equally from their expertise. I think too many relationships ends up being either surgeon being the boss or the scientist being the boss, which is a little less. Yeah. But when one dominates, you don't end up with the best product. So I think, like from my perspective, I've been fortunate enough, so everybody I work with, they ended up becoming my friends, or we were friends before we did. So everything always worked out well. So I think that developing a relationship is really important. And then also for young people, if you want to do something, like, I work with everybody. As long as they're willing to contribute, do their part, I'm happy to work with them. So, I publish papers with almost everybody because of that, because you don't need to reinvent the wheel. If somebody has it, you go out and do it. And if you want to develop it yourself, like a lot of the things in Gus's lab was based on them visiting and looking at my stuff, and I gave him all the requirements and so forth. So I think if people like Jim or I, if somebody wants to invest and learn from us and copy from us, I mean, have at it. We're always open. But again, they can reach out to us, but they need to, so the surgeons, I think most important message I can give young surgeons is that if you want to do this, you should be committed, inquisitive, and just try to answer whatever the question that you have best as you can.
Yep. It's not, hey, this is my idea. You do all the work. It's a collaboration. Yep. Well, it's great. Thanks, Jim. I think we'll go to Scott now. And again, we're lucky to have Scott here, and we're going to switch a little bit of gears. And Scott, hopefully you can pull up your slides here, and that Scott's going to talk about animal models and shoulder research, his experience, and potentially, how can, again, someone that's not necessarily been exposed to this in their own research environment, how they might be able to kind of start to introduce this. So Scott, thanks again.
Thank you. Am my screen sharing okay?
Yep, it looks great.
Great. So thank you. So that's a nice talk, Jim. That's a great overview there. And what I'll describe here is, some of those, we'll go through animal models here, but some of the biomechanical testing techniques you just had a nice discussion about. You can use those same techniques in your animal tissues as well as your human cadaveric work. So that's just a place to kind of start. So we'll talk a little about animal models here. Start.
Perfect.
Disclosures
No
there. Actually, I put in these points here based on the discussion. I just put in, these are the 3 points that came up, and I was going to emphasize them. So I added a slide. These just came up, and I would just emphasize these points that were just discussed. Develop a collaboration between the surgeon and scientist, critically important. Ty, you mentioned the important point about do a literature review. If you don't know history, you'll repeat it. And then nothing will kill a grant quicker than if it's evident that you've not reviewed literature. And the other point that came up, don't be afraid to set up a visit to a laboratory to observe an animal models or evaluation techniques we'll kind of go through here. So animal studies can certainly play a fundamental role in translational research. And, the clinician scientist, and by that, you can be involved in clinical research or laboratory research. But I think we want to move patient care forward here. And talk about laboratory research. It's a corny phrase, but bench to the bedside is still very apt. You can do laboratory research. There's preclinical animal research, and then ultimately clinical research. But ultimately, that's how we move patient care forward. We're going to talk a little about the preclinical models. So some general considerations when choosing an appropriate animal model. Lou Suslowski done some very nice work in this area years ago, back in 1996, kind of a classic paper. We looked at a number of animal models and kind of established the rat model, for example, as appropriate for rotator cuff models. But some general points here. You obviously want a model or an animal that simulates, of course, the clinical condition and the pathology. And that's not just the anatomy, but also the underlying pathology. Generally similar anatomy, enjoy mechanics to human, and understand that most of our animal models are quadrupeds. Some have used, monkeys, but by and large, that's unusual and costly. And so we do understand these are quadrupedal animals. Cost and animal husbandry always become considerations as well. Other considerations. Start by asking, what is your goal in your study? If you want to study underlying tissue biology, you may start with small animal models, rodent models, mice and rats. They're often appropriate for studying basic biologic mechanisms, and the real value is the availability of transgenic models, gain of function and loss of function, knockout models, which really allow study of molecular mechanisms. We also, for rodent models, we have the reagents to study gene expression. We have antibodies. We've got all of the RNA probes, things like that. So the reagents to really do careful analysis of tissue composition, structure, and gene expression are much more available for rodent models. In contrast, if you want to study implants, surgical techniques, or really more some biomechanical aspects, you may use larger animals. And in general, sheep and goat have been used. Dogs have also been used in this area as well. Another general point to put out at the outset here is choosing your time points for animal sacrifice. Again, depends on your question. If your goal is to study the earlier biologic events, you may choose those, smaller animal models, earlier time points. In contrast, you may be interested in the later events in tissue remodeling, tissue healing, ultimate strength properties, biomechanical testing. You generally do more to your later time points. So All of these are considerations: what animal to use, what time points to use. Depends a lot on your underlying question. At the end of the day, exploring a given area, you may start with small animal models to look at some of the biologic mechanisms and then graduate over time to larger animals. So let's kind of go through a little bit. Another critically important consideration is, how can we control mechanical loading? In fact, a major limitation of our animal models is, in fact, the difficulty controlling joint loading postoperatively. Obviously, mechanical load is so critically important to not just joint function, but the biologic events. Well, it's hard for us to frankly control mechanical loading in our animals, but here's some thoughts for you. We can immobilize animals. Botox injections have been used to paralyze the muscles around the shoulder. We and others have used that. It's a paper we published actually in the knee. We've used this in the knee and shoulder. It's not perfect though. I mean, Botox will paralyze the muscles, and the animal's kind of dragging around a limb over which they have no control. So there still may be some micro motion. So, but it's an option for you. Some have used immobilization with casts or bandages. This is in a rat model. This is use a vet wrap material. Some have put a little vet wrap material around the shoulder girdle like this, and a small layer of polymethyl methacrylate to kind of harden it so the animal doesn't chew through this. This is usually pretty well tolerated by the animal. Slings have been used. Actually, dogs are pretty compliant. You can actually sling and mobilize the dog's extremity. Sheep, Christian Gerber, in kind of a classic paper in 1999, described actually using slings harness actually to suspend an animal actually from the roof in the barn. This is probably difficult to do in this country ethically, but a way to kind of unload the joint. We've actually done this as a sheep hind limb. We've done that in the hind limb. Just an example of some thoughts for you. That's a hind limb, not a shoulder, but some ways to sort of protect loading. We've also tried actually taping a softball to the hoof in large animals, both in sheep and goats, to try to discourage weight bearing. It didn't really work out great. They kind of fight it. So I'm not, they end up sort of loading the limb because they fight it. So that's not really worked out well. So, but these are some thoughts on limiting motion. And the other side of this coin is overload. We can use treadmill running, generally only practical for rodents. We have a treadmill we've used for years for mice and rats. Lucislawski's started doing this some years ago in the shoulder models in the late 1990s. And to give you a little sense here, I kind of outline his general protocol that we've used. We've made some modifications, but you want to go through an acclimation period for your animals. And you'll find some animals that just don't run, and just don't include them in the group. You need to kind of train them. Most will run. We've usually used treadmill running at a decline. Decline running simulates eccentric muscle loads, and the eccentric loading does load the tendon more. And we know there's a higher risk for tendon injury with eccentric loading. And this protocol you see here results in approximately 7,500 strides per day, something like a swimmer might use, might do in a swim practice. We have used in our animal models here, in this treadmill here, a little shocker that you can put at the back of the treadmill. So if the animal stops running, and it's ethically sound and provable by IRBs, it's tolerated by the animal, but it's a gentle shock. So if they stop running, when they hit the back of the treadmill, it gets a little shock, and it keeps them running. You will find some animals just don't run, and you have to take them out of the protocol. So plan that in your power analyses if you're trying to think about doing this. But this is a way to kind of induce sort of overload, if you will. Just some other examples. This is in the knee model, but we have used external fixator devices quite a bit in rats and mice. This is an example. It's an X-ray here. Actually, we started to develop one now, an X-fix in the rat shoulder. Pretty easy to put pins into the humerus. Scapula, of course, much more challenging. We've actually worked this out with small 30 gauge needles. So, but anyway, post-op rehab. Again, following on this talk, this thoughts about how you control mechanical loading, we need to develop more realistic ways of developing joint loading. This is, again, our knee model, but I want to show you what we've kind of done in this area to sort of, we've developed a CPM device that this video plays, so we can actually put the animal under anesthesia in this computer-controlled device, take the knee through a controlled range of motion. We need to do something like this for the shoulder. We can really, truly control. So maybe you mobilize the shoulder all day, and then you apply the known amount of loading. We can control onset, frequency, duration, and magnitude of load in doing this. And so again, we've used this in the RACL models for a number of years, interfacing this external fixation device through this computer-controlled mechanism. We've published some papers on this. We've not done this in the shoulder, but this is just some food for thought for you to show you what we might be able to try to start to do in the shoulder to really do some controlled loading. Let's go through some specific models. What about subacromial impingement models for tendinopathy and in the shoulder? Some years ago, Lusoslawski used an allograft placed, Achilles tendon placed under the AC arch to induce compression of the supraspinatus tendon. Christian Gerber and his group have placed some bone under the acromion to induce impingement. Both of these are reasonable models. Some have used collagenase injection to induce changes that are in the tendon that are essentially mimic the early structural and compositional changes that you'll see in tendinopathies. In a patellar tendon model here in a rat knee where we've injected collagenase. It's not perfect, but the collagenase does, essentially it's an injury model, and you get real inflammatory environment. You get some changes in structure of the tendon at the cellular level, and you see tendon remodeling that are consistent with the findings of early tendinosis, but it's not perfect because this again is an acute injury, and those tendons go on and they heal. So it does not fully simulate the kind of chronic tendinopathy model, but this is something that's been used in many animal models you see in the literature for years, a collagenase injection. So it is something, a consideration for you. Frankly, what we've tried to do is do a mild collagenase injection to induce some injury and then run the animals on a treadmill to sort of make that acute process chronic. And that's another thought for you to develop a tendinopathy model. More recently, we've developed an animal model, a mouse model of subacromial impingement, putting a small clip into the subacromial space. This is a mouse here. See a little metal clip in the subacromial space here. Nice thing about this is it's quite easy to put this clip in. It can be removed, so you can simulate later acromioplasty. So you can kind of reverse the subacromial impingement. This is a paper we published this model several years ago. If you look at the normal mouse rotator cuff is here, the impinged tendon here, we can quantify that histologically with this Bonar score. You see the clip impingement group, clearly abnormal histology. Mechanically, we see alterations in load to failure and stiffness. So we can predictably induce alterations in tendon material properties, structure and composition, putting this small clip in. And we've used this model now quite a bit to test various some therapeutics. We've used this to look at mitochondrial function and dysfunction in the mouse shoulder. So it's a model that's available to you. Rotator cuff repair models, true direct repair models, a number of animals have been used over the years, from rodents, mice, rats, rabbits, dogs, goats, and sheep. I've done rotator cuff repairs on all these animals over the years. And again, different animals have different purposes. As we mentioned earlier, small animals, rodent models to look at some of the molecular events. Larger animal models have different purposes here. Most have used an acute detachment followed by immediate repair, but of course that does not simulate the clinical condition of tendinopathy. More recently, we and others have used models where you detach the tendon followed by repair kind of 4 to 6 weeks later. You can probably, this is a picture showing a Gore-Tex material covering the tendon, so you can you could prevent adhesions of the tendon to the surrounding tissues. You can wrap the tendon. Some have used a silicone tube. Similarly, as you wrap the tendon, when you go back anywhere from 4 to 8 weeks later, you can easily find the tendon. It's not scarred in, but you do see some changes in the tendon that are more consistent with the underlying tendinopathy. Most animal models use sutures through drill holes, as you see here, often with the little plate. Sometimes the sutures are a plate here. But suture anchor repairs can be used in some larger animal models that will accept suture anchors. But most models have used sutures through drill holes. Again, back to Lusoslawski's nice work in the rat model, where we popularized using a rat for a rotator cuff model. He looked at a number of animals and found that the rat shoulder anatomy and the osseous anatomy quite similar to the human as far as the coracoacromial arch. And you see that on the lower left, and then the pictures on the lower right, some nice x-rays at various, the animal during the stance phase demonstrates how the tendon passes under an enclosed acromial arch. So pretty similar to humans, where you do have tendon under this arch, where you may have the potential for impingement. So the rat model has been used quite a bit for shoulder research here, for rotator cuff in particular. Let's go through some pictures very, very kind of rapidly. As far as the surgical exposure, standard is an incision over the shoulder, expose the deltoid. We split the deltoid in line with its fibers there. Here's the supraspinatus tendon. That's what we've typically used. See the acromion mark there. we've often just kind of put a small hook under the acromion to kind of retract it and kind of pull it up superiorly to expose the supraspinatus tendon. You can put a small clamp underneath the tendon here to isolate it. Go ahead and put your suture in first. We've used a 4-row suture here. Put the suture in first and then detach the tendon. Here's the tendon having been detached. Kind of decorticate your greater tuberosity with the scalpel there. And then place 2 drill holes, typically like a 23 gauge needle drill, 2 crossing drill holes in the greater in the proximal humerus and the greater tuberosity there. Pass your sutures through. Now you see the sutures are tied laterally on the right side. That's over the lateral aspect there. We've tied the sutures down. You see the repaired tendon. So reapproximating tendon to bone. We then developed a mouse model, and others have used this as well. And the goal of the mouse model was to allow use of transgenic animals so we can really examine the molecular mechanisms that are involved in tendon degeneration and tendon repair. And again, using transgenics allows you to use gain of function and loss of function models here. It's just some pictures. For the mouse model, this is a paper we published some years ago. We've used a 6-0 proline suture, place a modified Kessler suture. The tendon is then detached from the humerus afterwards. And again, like in the rat, we placed 2 crossing bone tunnels. In the mouse, we've used a 30 gauge needle. Mice are small, obviously. I could not overemphasize the importance of microsurgical training. Clearly, you need to use a surgical microscope or loop magnification would be very helpful for you. We've generally had our surgical fellows use loops or a surgical microscope and really train. We'll have them go ahead and do at least 30 cadaveric dissections and repairs for practice, because it really makes a difference. The smaller the animal, the more technically challenging these can become. So I can't overemphasize the importance of extensive practice on cadaveric animals before you go ahead and start your study here. For large animal models, the sheep model has been used for years. This goes back to work Christian Gerber kind of popularized using sheep some years ago. Simon Turner at Colorado State has done a lot in this area. We've done a number of sheep models over the years with Simon Turner at Colorado State, typically using the infraspinatus tendon. And this does allow evaluation of realistic size implants and suture patterns. Here's the sheep here. The osseous anatomy of the sheep, a little bit different than the human, but you see the spine of the scapula. They have a big greater tuberosity. Grossly, here's after you retract the deltoid, here's the infraspinatus tendon attaching to bone. So generally pretty similar. Again, it's a quadruped like all these, so there are real limitations, of course. And then sutures through drill holes, tie these sutures over a little plate, as you see on the X-ray here. We've used the sheep model for quite a number of years to evaluate various biologic augmentation techniques. Just to show some pictures, put a collagen sponge on the left side at the tendon bone interface. You see sutures brought through a drill hole. On the right side here, you see this collagen sponge. Again, this is where we look at BMP12, but again, these larger animals let you look at these implants here. An important point about the sheep model: despite protection of these animals, they're trying to protect them. These repairs, frankly, they all detach and they fill in with scar tissue. If you use your MRI scan here, look at these MRs on the right side here. The actual MRs demonstrate this interface tissue clearly different signal between the interface tissue and your low signal tendon there. So really, these are kind of a model of a failure in continuity. If you look at this gross specimen, there's tissue attaching from tendon to bone. There's no defect there. So it's different than in our in humans where the tendon fails with the defect. These animals are robust healers. They fill in with scar, but there is this failure in continuity. So really, it's kind of a model of gap healing, and that's an important distinction and limitation of these large animal models. And it gets back to the difficulty in truly protecting loading in these animals. But the value of the large animals, you can use ultrasound. We do ultrasound in the awake animal. We've used that in sheep and goats. And again, you see these gaps form. This has been the experience of us and many, many others, kind of everybody. So if you look back at your animal, your gross specimen, you might go, oh, these are all intact. Do your MRI and you'll see this views on the right. So these are this failure in continuity model here. Another model that Christian Gerber's popularized is doing a greater tuberosity osteotomy. You see the tendon detached here with a bone chip, and then he wraps it in a silicone tube. So you can go back later and do a repair. This allows you to kind of repair bone to bone. So another model that has been used in the sheep here. Briefly on the biceps tendon, we've used a rabbit for some models of biceps tenodesis. Just some pictures here showing the biceps attachment or reattachment model in the rabbit. Its size is appropriate to allow suturing through a drill tunnel or to the surface of bone. And so we published this as a model you can use if you're interested in the biceps tendon. Rat biceps is usable but very, very small. And rabbits are much more economical than, say, going to large animals such as the sheep. And lastly, think about doing clinically relevant imaging. You can do Faxitron. This is actually, Bob, from one of your nice papers from JOR last year, a nice high resolution radiograph. We have used Faxitron as well, and I found your nice paper. It's a great picture here in the rat model here. Micro CT here in rat. This is a mouse here. This is, we can do our CTs in our animals and imaging studies. Even more importantly, we've gone to doing in vivo molecular imaging. This is using gallium-68 labeled PET scanning with a marker for activated macrophages. You can do a nice thing about in vivo imaging is you can do serial imaging in the same animal. So again, you need to be affiliated with facilities that can do these techniques, but these are all neat techniques for you. We've used micro CT quite a bit in the rabbit and as well as rat there, and to really look at trabecular new bone formation at the healing tendon bone attachment site. So think about the imaging that you can do. Power studies are obviously critically important. You start that with your primary outcome measure that you want to use in your study. You need to start by identifying what is the predicted difference you want to detect, and then you need to know the standard deviation for the measures you're making. But some general estimates I put here for you, and these are general estimates. They'll depend again on your particular outcome measures. But generally for histology, you're using 4 to 5 specimens per time point. Gene expression, typically 4 to 6. Mechanics, you need a little bit more, just because the standard deviations can be substantial sometimes. So generally, we're kind of 7 to 10 specimens per time point. Imaging, you're kind of 3 to 5. Imaging is more of a semi-quantitative analysis in general. And lastly, my last slide here, collaborations are really key to a successful program. And I just kind of list here all the collaborations that I've established over the years here at HSS and all of the different facilities that help us with our research. So on your animal facilities, of course, but also working with biomechanics, working with imaging, small animal, large animal, the molecular imaging I mentioned, your genomics facilities for some of the transcriptional profiling. Important point here is collaborations are critically important, and we'll stop there in the interest of time. Thank you.
Thanks, Scott. That was awesome. It's perfect. I think it really gives us a great overview with regards to really what it takes to be able to do high-level animal research. And I think, you hit on a lot of the major points that that it's an enormous endeavor to be able to start to introduce this into the work that you're doing, especially as a clinician, where we have to see patients and do surgery, and we have to be orthopedic surgeons that at the same level to include this as part of what we want to do, that you really need a host of people that are there to work with you. And having, again, done this as well, so that I can tell you that you have to be the ringleader, that it really has to be you pushing the ball forward, and you getting the guys involved or the gals involved that actually have the expertise. And it's interesting, even submitting grants. Like I'll submit a grant, and there's there might be 5 PhDs on the grant, all with their own labs that are on it, and that you need that to be able to make this work. And it's interesting talking to some of my partners in this that are PhDs. They're like, yeah, Bob, you're basically you're the ringleader. That's you might not have an expertise in all the different areas of the science, but you're the person bringing it together. And I think that you have to be ready for that. The surgical side of it, it's interesting. You bring up a lot of great points. I would 100% agree with you that to do a mouse model, smaller animals, for me, what it means is collaborating with one of my hand partners, honestly. So we do the surgery together on the animals, but I'm basically holding retractors, while my partner who does microvascular repairs, he's the one that's actually doing the surgery. And unless you're doing that type of work on a daily basis, I think it then would create an issue with regards to questioning the reliability of the data that you're actually producing, because potentially the constructs aren't consistent. A couple questions. One is you know, what do you think with regards to, you brought it up in your talk about small animal models really looking for gene expression and really looking at biologic pathways with regards to how certain either repairs or biologics or whatever you're trying to study. Whereas if we're really looking at biomechanics to using larger models. That being said, most small animal models, biomechanics are done. And it would be great to hear your thoughts. Do if the biomechanics don't play out, does that mean that this is not an important biologic, that we're not looking, that this is not important? Right. Or is that just an added benefit? And partly I say this is because as orthopedic surgeons, we like to break things in the lab. And if you can't necessarily show that there's a biomechanical difference, then there's a tendency to discount the data. And so it'd be good to kind of hear your thoughts on that.
Yeah, so exactly. So depending on what your primary outcome is, and in general, you're right. I agree that our primary outcome is generally then we want this to be stronger. But I would submit to you that there's more we should consider. For example, what about there should be more and more attention to measuring animal function, almost pain. I mean, at the end of the day, we're doing a lot of these. Say you have a better quality tissue histologically, compositionally that functions better. It may not be stronger necessarily, may not be stiffer, but it's more normal tissue. That may affect joint function. So we started to use treadmill. We are not treadmills, but even a computer.
Have you ever used like cage activity to be able?
Or a gait analysis model,
right.
Or a gait analysis system where we can really quantitate or quantify gait parameters, cost strike, cadence of walking, and things like that. So as measures of function, I think measures of animal function, which probably indirectly reflect pain, is one another important outcome measure for you. But certainly, if at the end of the day, mechanical load or both, whether it's failure load, strength, or stiffness, are important measures, and maybe not ultimate load we should measure, but more response to repetitive cyclic loading, for example. So again, it's back to the basic question that you want to answer.
Sure. With regards to, again, we've also seen this again with some grants that have been pushed in through that have kind of been submitted. Obviously, there's a lot of resources that are required to be able to make this type of work happen. And if you wanted to start to move down this road, kind of what's your best advice to surgeons that are in academic environments to be able to start to move in this space that could probably do great things in terms of pushing science forward, but maybe don't know exactly what's the right first step to be able to actually start to do this work?
First thing is choose an area and have a passion for it. I mean, I love what I do in research because I have a passion for it. So that'll make it easy to put all the hours in that you need to do, because it takes hours. And to more directly to your question, Bob, I think you can start, as we said at the outset, establish a collaboration. You need to try to work with scientists, maybe a veterinarian, to where you have access, of course, to animals that you can work with, and then don't be afraid to contact myself or others and go observe someone who's doing these animal models and see what tools they use, see what kind of loops they use, what kind of surgical microscope is used. Don't be, it's time well spent to go spend a day or two. I've had individuals come to our lab and do that, just kind of see the models, and not just the surgery, but the outcome measures. So how do you do your biomechanical testing? Back to your earlier point, we certainly do mechanical testing even in our small animals. You need the microstructural, your micromechanical testing setups to do those testing. So I would encourage you to go visit someone who's doing these models, establish a collaboration, then you kind of go from there. And certainly you need to be in a facility or in a structure where you have access, of course, to the laboratory and the resources you need. So admittedly, but whether you don't have it right at your institution, maybe you go somewhere locally in your city where you can hook up and collaborate with individuals doing this work.
I guess on similar lines, that it's interesting that to the initial inertia to get this type of work, part of it done is money. and that a lot of this costs money. And so I personally have ideas with regards to that. It would be nice to hear kind of your thoughts. One of the most critical aspects to me about getting the money to be able to start to do this work, and I would again highly recommend this to maybe any fellow that might be watching this or whatnot, is make it part of your startup package. That if this is an area of science that you actually definitely want to move into, try to develop some expertise, or at least exploration of this as a resident or a fellow. And then as you move into an academic setting, to be able to create some type of initial funding line from the institution that you're joining to be able to partially support this, because it definitely requires money and space. And, it's not as exorbitant, I think, as you might consider. That, you can do really good work for $150,000. You can get a lot of the things set up that you need to be set up, but you don't need a 5-year R01 to be able to actually start to do this type of work, but you need some source of money. So for me, when people have asked me, it's like, you have to make it part of the startup. Any other thoughts about where, people that don't necessarily have the initial funding to get through that inertia to get the project going, where to potentially to go after funds?
Yeah, first, I could not agree more with the importance of, if you really want to establish this in your career as you begin as a surgeon scientist, put this in your initial contract. Get some support, some part-time support for a technician to help you with this work. Yep. You need that support, and if you do this, it's value added to the institution, and you may, frankly, early on, cost the institution some money. That's okay. It's gonna be a lost leader, in so much as this brings, research at this level. It puts your department on the map. It puts you on the podium at your meetings. It attracts the kind of residents and fellows you want. So you bring real value if you commit to doing this. So don't be afraid to ask your chairman, listen, I'm willing to put the time in, but you need to help support me. Beyond that, to your question, you can start with, industry funding can be a good place to start, where you can start to do some small studies, get some funding in, and kind of get your hands dirty, start to publish some papers, and that allows you then to write grants. Certainly, you're going to then pursue peer-reviewed outside funding. Some of our national societies and foundations have good sources of support for young investigators. The ORF does, the Sports Medicine Society, Arthroscopy Association, Shoulder and Elbow, all these associations have the ability to support small studies, kind of pilot work that lets you get started. So you need to start somewhere. And again, frankly, industry money is a place to sometimes start, where you can bring in some funds to let you help support a technician, support some of the animal costs, and some of the funding that they bring in can help you hire a technician that can help you with studies beyond just what you're doing with industry. That lets you then write a grant, and it just kind of goes from there. And it's a process. I mean, to get an R01 probably takes you 7 to 10 years from initiating this process. You start with publishing some papers, and then you maybe get an OREF Career Development Award, and then you write your R01 and you don't get it the first time, and you rewrite it. I mean, you got to be patient, but you learn a lot throughout the process. Then you can be a real contributor in this field if you're willing to do that.
I think we oftentimes forget about industry funding, and we think that and it is I totally agree that it is an invaluable resource to be able to get very reasonable amounts of money that are not as competitive, as long as you are able to align the work that you're doing with potentially some of the interests of the company. And honestly, I think sometimes we want to say, oh, well, we're clouding our the data with money that is coming from biasing the data. But I think that there's ways to be able to approach that so that you understand that you're going to publish what you publish, and that's the agreement that you make with industry. And that I think that for getting initial work done, it's great advice to be able to get some funds from industry, because it's available, and the bar is definitely not as high as getting funding from the DoD or NIH or any of these, honestly, even from foundations that
Sure.
can be very competitive. So
That's right. I mean, clearly you have to avoid, there's obvious concerns about conflicts of interest that needs to be managed well. And,
Yep.
and I think the point you brought up, which is really important, you don't want to be working for industry. So you need to find a middle ground where it's something you're interested in enough. And maybe you find that middle ground where it's not exactly what you wanted to work on, but it's close enough, and at least it gets you started, you get some funds, and it's attractive enough to industry because they're only going to fund it if they get something out of it. So you need to really craft that well, manage conflicts, carefully look at your contract, so you make sure you have the ability
Yep.
to publish. The industry will have the ability to review the material, but make sure you're not limited in the ability to publish, because that's critically important. Make sure you or your legal team reviews those contracts. So it takes some doing. But again, it's a reasonable place to start.
it's great. Ty, any questions or thoughts?
Yeah, I think I just want to add to one thing that I saw a lot of this when I was a graduate student down in San Diego. And if you're at a big institution and your institution, other departments does a lot of animal research, you should go talk to them, because orthopedic surgery doesn't affect too many things, so that you might be able to piggyback on something to do some of the studies. We've done a lot of that back in San Diego. Second thing is, this is a question for both you, Bob, and Scott, is anytime I used to do a lot of animal research, and to me I thought it was too complicated, too many variables to trying to think. And when you're choosing your animal model, I know we've talked about the anatomy more at the macroscopic level, but if you look at like bone characteristics and the tendon characteristics, especially when it comes to bone, I see a lot of difference between flight animals and somewhat sedentary animals like dogs and sheep have very bone quality that's similar to humans. But if you look at rabbits or rats, they're very brittle bones. And I don't know if that comes into your consideration on what you're trying to study. And then if you're starting out, what criteria would you use to pick an animal model if you didn't have literature?
I have, Scott, why don't you go? I know I actually, with regards to the first question, I have definite thoughts about that. And some of them are not necessarily, there's not much you can do about it. But I think that it would be, it would be good to hear your thoughts first, though, Scott.
Yeah, you thought about bone quality. I thought about that a lot too, Ty. And I think we should do more characterization of bone quality. I use micro CT quite a bit in our cuff models to look at new trabecular bone formation at the healing tendon bone interface. That said, maybe we should characterize the time zero bone quality, because that may affect the subsequent biologic events. So yeah, that's an important point. Your last question, how do you choose the animal? Again, I think it's really back to what are your goals? If it's studying the early biologic events, the cellular and molecular mechanisms, you probably use your rodent models. If you're more interested in testing clinically realistic sized implants, you're going to use larger animals. Get large animals, you get into costs with sheep and goats. You also get into issues with availability, but don't discount that. It's pretty easy to do mice and rats at most places, even rabbits. Sheep and goats, New York City, we don't have those. I do my sheep work up at Cornell, Ithaca, or in Colorado State. And there are some contract research places around the country you can do large animals. We've done some primates in the past in conjunction with industry, with Genetics Institute up in Andover, Massachusetts years ago. So a lot of different considerations: cost, availability, husbandry, all those things.
Yeah. So with regards to bone quality, I think it's critical to be able to at least include that as part of the evaluation of whatever study you're doing. And I think, honestly, Jim had mentioned this about getting CT scans on his patients with regards to biomechanical studies. It's probably just as critical to include CT scans if you're going to actually be doing animal studies. That just relying on radiographs is probably not enough. The other thing that's interesting is that a lot of people, if you read a lot of the animal studies that are published, time zero testing is not performed. which is interesting. That a lot of it is time X point after intervention, and time zero mechanics are not necessarily included. And I've kind of been hammered this by some of the scientists where I am right now, that have been here 30, 40 years, that are, you have to do time zero testing as part of the evaluation. And the interesting thing about time zero testing in even rabbits or rats or mice is that if you time zero test a rotator cuff in a mouse, it's going to actually create a greater tuberosity fracture. So you are not going to actually rupture the tendon. So the bone is weaker than the actual tendon. And how that plays out in terms of, your model, we're testing mostly repairs, and actually all of the repairs fail through the tendon at the tendon site or the muscle tendon junction, not necessarily through the bone. But it does bring to the importance with regards to the quality of the bone and actually how you're fixating that. So how well is the suture being passed or held in the bone in something where the bone is the weak link and not necessarily the tendon. So if I was to say anything with regards to the issue with regards to bone quality, two things: CT scans and time zero testing. In terms of which of the animal models, we've also used the Colorado State group. They're amazing that they have everything there on campus, from you name it, from histology to gene expression to activity testing, imaging, MRI, CT scan. And if they don't have it, they're willing to process the samples and send them to wherever. If you want to do, some type of drug elution test that they don't necessarily have there, they'll prepare all the specimens and send them to whatever facility in whatever state to get it done. And the interesting thing is that another point that I would make is get a budget from exactly how much it's going to cost to do your experiments and shop it around. Go to different places to find out how much it's actually going to cost, because it may actually be cheaper to even bring it to a place and have them do everything, as opposed for you to home grow it. Or it might actually be almost within $1,000 the same, but it's going to be more wasteful for you to do it in a home location, because you have to go through the process of actually learning the methodology, perfecting it, and then being able to do your experiments. So I would say, having a good understanding of the costs and how much it would cost in other places that have other experience, you might be surprised that that it would be just as a similar price or cheaper to have someone else do the experiments. And if you're, does that make you less of a scientist? In my mind, no, because we're trying to push things forward to be able to get an answer. And, I don't know, Scott can say for himself, but does he feel bad that he sent an experiment to Colorado State to have them do the experiments? I can't imagine that he did. And we've done that. And we're actually planning an experiment right now for sheep. And we look to be able to do sheep up in Logan, Utah. There's at Utah State. And it would be more efficient for us to just bring it to Colorado State. And so that's what we're going to do.
That's what I've done. Yeah, I do the surgery, but I go out there. But yeah, exactly.
Right, you go do the surgery, but all the other parts of it.
Yeah, there's contract. That's a great point. There's a couple centers around the country. They're set up to do it. They've got it's just turnkey. They've got all the resources. They've got students and veterinary assistants, and it's oftentimes the veterinary school. So Colorado State, Cornell, Ithaca. They've got students and techs. Absolutely, it's almost the only way to do some of the large animal work. So that's for sure. And you're back on your point on time zero testing. Very important. I agree. Test your construct time zero. Also test time zero test your normal specimen.
Wild type.
What is the normal failure load of your tendon attachment site in a mouse, in a rabbit, in a rat, in a sheep? So yeah,
it's good. All right. Well, we've gone a little bit over, but I think, this was great. Both, ends of the spectrum, biomechanics and obviously animal models. I want to thank both Jim and Scott, as well as Ty, for being with us tonight. And again, this is going to, this has been recorded, so it's going to be available at a later time for others to be able to review. And Thank the participants as well as the ASCS for giving us an opportunity to be able to continue to move the ball forward with regards to research. We will have a third webinar later this year in the fall, and those that are on will be able to get you links and emails for that webinar to come over the course of the next couple months. So again, thank everyone tonight for joining us, and otherwise have a good night.
Thanks, guys.
Nice job, Bob. Thanks so much for Ty and Bob for organizing this. I enjoyed it. Thank you.
Great. Thank you. Steve, we good?